Alrighty, so with it being 1 minute past the hour, we're going to go ahead and get started. Thank you all for joining our webinar tonight, Protecting and Improving Healthcare Access. We're really happy to be talking to you all about this. Mark, next slide. So what are we going to be covering? First, I'll go over the usual introduction and housekeepings to remind you all of how this works and introduce you to our lovely guests. And then we're going to do a deep dive on promoting access to personalized medicine. Then I'm going to talk about Medicaid coverage developments that have happened in the last couple of months, increasing access to genetic counselors as kind of a follow-up from our last institute last month, and then some developments in private marketplace and drug affordability developments, and then of course our usual Q&A. As always, feel free to drop those questions in the chat as things go. But before I get there, if you do need closed captioning, that is on the far left side of your screen. You will see that little speech bubble, and that'll give you closed captioning. To use the chat function, it's over on the far right side of your screen. And then for the Q&A box, if you hit those three little dots a little past the chat icon, you'll see the Q&A box, and we'll get those questions either squared away as we're talking, or if it's relevant to the Q&A, we'll handle it then. There you go. So you all know me. My name is Joel Gartner. I'm Director of Access Policy here at MDA, so I handle all of our healthcare priorities. But you don't know our two guests. With me tonight, we have Morgan Anderson Brooks. She is the President at Innovation Policy Solutions. She lobbies and consults on a broad range of health and science policy issues, leveraging her expertise as a researcher in the field of neuroscience for over 10 years. She specializes in implementing federal policy solutions that help create, advance, and result in the adaptation of technological innovations. She previously served as Vice President at CRD Associates, and additionally advocated on behalf of the neuroscience research community while at the Society for Neuroscience during an Eagleton Institute of Politics awarded a fellowship and placement at the New Jersey Department of Health. She partnered with colleagues in the development of a successful CDC awarded program to prevent and control chronic disease in the state. Megan holds a PhD in neuroscience from Rutgers University. We also have with us Lindsay Trischler, that's my bad, too many I's, joined the Innovation Policy Solutions as principal in October of 2022. She has over 7 years of experience in advocacy and consulting, and her professional expertise encompasses the appropriations process, coalition management, insurance benefit design, and patient access to affordable healthcare. Prior to joining iPolicy, she was a senior policy associate at CRD Associates, where she advised a range of clients, including patient and public health advocacy organizations, academic research centers, and professional medical societies. She began her career in policy at the International Myeloma Foundation, where she was responsible for state and federal advocacy and managed their grassroots program. So now that you know who everybody is, we can go ahead and get started, and I will pass it off to our panelists to talk about precision medicine.
Well, hello, everyone. Thank you to the Muscular Dystrophy Association for giving us the opportunity to talk about policies to promote access to personalized medicine. My hope is to give you provide some information about a range of topics that we've been working on and that we're aware of in the personalized medicine policy space, and really appreciate your time and your attention on these issues that are very important to us. Next slide. So to level set, I thought we would just first address what is personalized medicine, just in case you're not familiar with the concept, and no better institute to turn to than the National Human Genome Research Institute within the National Institutes of Health, which defines personalized medicine as an emerging practice of medicine that uses an individual's genetic profile to guide decisions made in regard to the prevention, diagnosis, and treatment of disease. Next slide. And we are very lucky to have a whole congressional caucus devoted to issues impacting this important area of medical practice. In particular, we have three champions that we work with closely, and many other advocates in the personalized medicine community work with very closely. The co-chairs of the caucus are Congressman Eric Swalwell from California. We have since had a Republican co-chair step down because of his role in leadership and needing to take a step back from most of his other efforts. And so we're working to identify a Republican co-chair as we speak. So I hope to have some very good news with you to share with you soon on that front. But then turning to the Senate side, Senators Kristen Sinema and Tim Scott have joined together as partners to champion various personalized medicine policy issues in that chamber. And in general, the caucus works to shape legislation that encourages all aspects of that are needed to go into advancing personalized medicine. They educate other policymakers about the benefits of this area. Perhaps you've been to one of the congressional briefings that they've held on an array of topics. And as part of that education effort, they promote discussions about public policies that may encourage investment in personalized medicine development or facilitate its adoption within health systems. And they're always thinking about opportunities to shape the healthcare system in a way that facilitates access. Next slide. So, what I thought we would do today is focus in on two topics in general that the Personalized Medicine Caucus has been focusing on. The first area being that they're working to advance policy towards ending the diagnostic odyssey that many pediatric patients and their families face, in part by enabling access, in particular promoting coverage of genomic and genetic testing, and that being an array of different kind of genetic and genomic testing, whether it's panel testing where we're looking at a selection of a number of genes, or we're talking about whole genome sequencing or whole exome sequencing. Maybe you've heard these terms. And then the second issue being that the caucus is very interested in improving medication management and reducing adverse drug events through the use of adoption of pharmacogenomic information when clinical decisions are being made. So we'll start by focusing on the first topic, and I'm going to turn it over to my colleague, Lindsay. Next slide.
We can go to the next slide. So as Megan mentioned, one of the issues the caucus is working on is helping patients, particularly with rare diseases, get access to genetic testing in order to receive their diagnosis sooner. On average, it takes 14 different genetic tests and 5 misdiagnoses before a patient gets an accurate diagnosis, which can take up to over 3.5 years. And it's important that patients get an accurate diagnosis as soon as possible because in many cases, this helps their doctors quickly identify different treatments and therapies that are most likely to succeed, which often lends itself to improved outcomes. So while there is widespread acknowledgement that genetic and genomic testing is a really important tool, there are still barriers that have made it difficult for folks to access this very necessary care. So the first main barrier is that there's just a general lack of clarity on insurance coverage for diagnostic tests, particularly for pediatric patients. Private insurance often follows the coverage decisions that are made by public insurance, which in this case would be Medicaid. And there's pretty poor guidance and inconsistencies in those coverage policies, which makes it hard for families to have affordable access to these testing options. And then another large roadblock is that rare disease patients that are in underserved communities experience even worse outcomes because there's often even less access to genetic and genomic clinical services, and they often struggle to understand how to access them as well. So we can go to the next slide. Luckily, there's a solution. So this brings us to the Precision Medicine Answers for Kids Today Act, which we have nicknamed the Answers Act. And there are 3 pillars of what this legislation would do in order to work to remedy and remove some of these roadblocks. So the first is that it would require the Centers for Medicaid and Medicaid Services, or CMS, to issue guidance to states on diagnostic coverage requirements under the Medicaid program, as well as provide them with education and support for healthcare providers, patients, and their families on how to access these genetic testing services. The bill would also create a 3-year demonstration program for up to 15 states that would provide coverage for genetic and genomic testing for undiagnosed patients. And the legislation puts a priority on states that have historically underused clinical genetic and genomic services. So those states would get top priority for participation in the program. And then the third big pillar is that the bill would require CMS to conduct studies on access to genetic testing services, especially in those underserved and marginalized communities that I mentioned before. And then they would then create a report on Medicaid coverage in each of the 50 states. That would give us a better idea of the access folks have. So the current status of the legislation is that we are working to find a Republican co-sponsor in the House to join Representative Eric Swalwell and Scott Peters, who have already committed to reintroducing the bill. We believe this is a very bipartisan issue and want the leadership on the legislation to reflect that. And then in the Senate, we are working with Senators Susan Collins and Mark Kelly and Bob Menendez from New Jersey, who last Congress introduced legislation that is very similar to the Answers Act. And we are having conversations with them about possibly introducing a bill that would be identical to the Answers Act in the Senate. So there would be companion legislation. And go to the next slide. We are also working another angle to try to reduce some of these barriers, which is using the appropriations process. So the Congressional Personalized Medicine Caucus has supported several appropriations report language requests that aim to increase access. And it is important to note, though, that report language is not legally binding. It accompanies funding bills and it is a way for Congress to explain how they would like federal agencies to spend the money that they're being appropriated, but they're not mandated to do so. So we can go to the next slide to look at some of the things that we've done so far. So for this next upcoming fiscal year 2024, which is supposed to start on September 30th, stakeholders have worked with the Personalized Medicine Caucus to get report language requests into the Labor HHS Appropriations Subcommittee, which works on the budget for the Department of Health and Human Services. And that language would encourage the National Human Genome Research Institute to work and coordinate with the National Institute of Child Health and Human Development to increase awareness of genetic and genomic testing, including different types of testing like whole genome sequencing, whole exome sequencing, and gene panels to help, increase the speed at which people are diagnosed with their rare diseases. We are still waiting for those draft reports to be released. I think the Senate is due to release their report any minute now. And once those are out, we'll be able to confirm whether or not that language was included. But we do have good news that in the last spending bill for our fiscal year we're currently in, FY 2023, there was language that was included that kind of mirrors some of the pillars of the Answers Act, which would encourage CMS to develop guidance for state health officials on their best practices for incorporating genomic and genetic testing into their Medicaid CHIP programs as the first line for is the first step for diagnosing children who are suspected of having a rare genetic disease. So again, would help reduce the diagnostic odyssey that kids and their families often go through. So the language that was included directed the agency to provide a report to Congress, which we are hoping is being released this summer, on the steps that they're taking to develop that guidance and the kind of information that they're looking at to inform what guidance they put out. So with that, I will turn it back over to Megan to talk about our second topic.
So let's turn to pharmacogenomics. To ensure everyone's on the same page, PGX testing helps doctors determine which drugs and dosages are right and which ones to avoid based on each patient's genetic information. So it's essentially precision medicine for medication management. It's personalizing those decisions that you make when we're deciding which prescriptions to have. Prescription drugs to use. So we're really talking about a shift in a paradigm. So when you think about the way that medication, the development of therapies has traditionally taken place, we're talking about, a drug using a development process where it's a one-size-fits-all approach. And so we're really thinking about that medication being used by a range of individuals and all in the same way. And we all understand that we respond differently to medications. And so I love that we're finally shifting into, taking a more specific approach to the way that we think about prescribing medications, in part by thinking about the way that we metabolize them and how our genetics influence the way that we metabolize those medications. So the shift in the paradigm is really moving towards a personalized prescribing approach where we're taking, we're thinking about taking this medication, but we know that certain genetic variants influence the way that medication is metabolized. So let's test this patient for pharmacogenomic variants of interest, combine that information, and we'll make some decisions about that person's therapy plan. So perhaps that person takes a normal dose, perhaps they take a lower dose or a higher dose, and perhaps to avoid an adverse drug event or promote a better response overall, we decide on an entirely different alternative. Next slide. So the hope is with PGX, we can do better. In this country, we have 1.3 million emergency department visits every year due to situations where an individual is harmed by the use of a medication. And that's not really the way we think about medications, right? We think about medications helping us, but that's not always the case, unfortunately. In fact, every 2 minutes, a life is lost because of non-optimized medications. And what's really key here is about half of these events that we know about are preventable. And that's key, the ones we know about. And I won't get into that issue, but at least half of them are preventable. And a huge chunk of them, is pharmacogenomic implications there that we can start thinking about. And really, this is not just, a small number of patients. We're talking about the whole population. And a study on the veterans population, they estimated that about 99% of patients have at least one genetic variant that impacts how our bodies respond to the medication. And considering how many adults are on at least one prescription drug and how many people are on more than one prescription medication, suddenly we're talking about a very big impact. Next slide. And I want to take a step back because I want to make it clear that PGX testing differs from diagnostic testing that we traditionally think about. So PGX testing identifies how a patient metabolizes a drug based on their genetic information so that we can make those drug and dosage selection decisions that are best for a patient. Whereas when we're thinking about a companion diagnostic, those tests accurately and reliably detect a biomarker so we can differentiate between patient populations that might benefit from a therapy for the condition that they're experiencing. And so we're really taking a completely different approach and not necessarily talking about testing that informs whether it's appropriate for someone to take a gene therapy or not, as an example. So next slide. We are talking about a lot of commonly prescribed medications that might be relevant to a range of different kinds of patient scenarios. So, you know, we're really thinking about genetic variants that affect the efficacy, dose, and safety of 50% of all commonly prescribed medications, and it's in a range of different drug classes. In different areas of medicine, everything from pain management medications, antidepressants. There's evolving evidence for ACE inhibitors, and the list goes on and on and on. So even if you know we're not talking about maybe the main therapeutic approach that's relevant to a patient community, it's also important to consider the other medications that a patient might also be taking to support improving their outcomes and their lifestyle altogether. Next slide. So we've sat down with a range of stakeholders to identify what are barriers to increased adoption of using pharmacogenomic information to make these prescribing decisions, and identified, and we'll simplify it for this evening or whatever time zone you're in, but we'll talk about 4 barriers in particular. So starting in the upper left, the lack of knowledge of the benefits of using PGX information among healthcare providers and the general public. There's many conversations I walk into where the person I'm speaking with has never even heard of the term. So often we're starting in a place where we're just trying to promote awareness of that this kind of drug gene association does exist in a lot of instances. And then moving down, we also have limitations within electronic health record and electronic medical systems that are being used that prevent healthcare providers from accessing and utilizing information about drug-drug interactions. So we're talking about the way that genetic testing results are stored discreetly in the EHRs, or thinking about the way that information is flagged for providers. Not all providers can be experts on PGX. So we really need to make it easy for people to understand, okay, I should probably be thinking about ordering genetic testing for this patient, or, oh, I see this patient has already been tested, and we should probably make some different decisions based on their results. Another barrier being the lack of reporting when adverse drug events are associated with a person's genetic status. We have really detailed databases on adverse drug events, but there's not an easy way to indicate when there is a PGX associated variant that is of interest to that adverse event that was experienced. And so we really think that that's a rich source of information that we could probably improve and tap into to promote a better understanding of drug-gene interactions. And then lastly, we're talking to many about the lack of sustained funding for PGX research. And within that, we're also talking about funding that comes from the NIH to support PGX guideline development as well, which is a really important part of providers even knowing when there are relevant drug-gene interactions that they should be paying attention to. Next slide. So one of the answers that we have to addressing these barriers is what we call the Powering PGX legislative package. Last year, there was a single bill that was introduced as the Right Drug Dose Now Act, and this year we've split them into 2 bills. So the first bill is keeping that original name, the Right Drug Dose Now Act. It requires several things. First, it requires an assessment and update of the National Action Plan for Adverse Drug Event Prevention, which was originally developed in 2014 and has not been updated since. And incentivizes those updates to EHR systems that I was alluding to and describing before. So in situations where a person's providers considering prescribing a medication and flagging when there might be interactions that would be relevant for making prescribing decisions. And this bill would also enhance reporting systems that would assist with the reporting of PGX-associated adverse drug events. And we are working with a range of members of Congress here. Once again, Representative Eric Swalwell is partnering with two new names that you haven't heard tonight, Dan Crenshaw and Deborah Ross. They've committed to working together to introducing the bill, and we're looking for an additional Republican member to join them as an original co-sponsor. And I've also been talking with a range of members in the Senate that we think would be just great champions on this issue. Next slide. The second bill is called the Pharmacogenomics Education and Research Act. It creates a provider education campaign on preventing adverse drug events in part through the use of evidence-based PGX information. And then secondly, it would authorize sustained funding for PGX implementation research and guideline development through the NIH. And Representatives Swalwell and Ross are working together on this bill. And once again, we're talking about both of these bills in our Senate meetings. Next slide. And then I wanted to take a quick opportunity to also talk about, again, Lindsay, we talked about working at different angles. And so this is another angle that we're working on, is using the appropriations process to fund really important programs. One of those key programs that we think is essential to advancing this conversation is the Department of Veteran Affairs National PGX Program. This program was based on a pilot program that the VA put into place, and it was tremendously successful. So they requested funding to change it into a national program, and last year's appropriations bill, they funded them at the requested level. And once again, we've been working to provide stakeholder support for that funding request, which this year it's $35.6 million. And we were pleased to see that both the House and Senate versions of the relevant appropriations bills included this funding. And we hope as we work towards seeing an appropriations bill that can ultimately become law, it retains this important funding. And then lastly, we continue to want to highlight NHGRI's role in supporting PGX programs and PGX implementation research, in particular, their work to fund the Clinical Pharmacogenomic Implementation Consortium, which is a body that develops consensus statements on scientific research that has emerged in the field. So I believe that's my last slide, and I'm going to turn it back over to Lindsay to wrap things up.
Yeah, so we, again, just want to thank you all for letting us come on and talk about this really important and exciting legislation. If you are interested in asking your member of Congress to be involved, there's two pretty simple things you can do. The first is to ask them to join the Congressional Personalized Medicine Caucus, and then also to support the Answers Act and the Powering PGX package. I don't see any questions in the chat, and I know we will have some time at the end of the presentation, but please feel free to shoot me and Megan an email if you have any other questions. So I will turn it back over to Joel, but thank you all.
Thank you both for that great overview. It's a really emerging and important area for our patient community. And for those of you that are wondering, where is MDA on this? We're working with all partners in lockstep, trying to get all these bills passed. So we're just as excited about it over here, and really excited to see where you guys can get this to go. But there are a few other happenings that have gone on in the last couple of months that we wanted to go ahead and update you on in the land of access. Firstly, we talked about this a couple of months ago when it first happened, but it bears repeating. Now we received a notification from CMS a few months ago that seat elevation systems are now covered for wheelchair users under Medicaid. So as of right now, you can go request your Medicaid office to cover your seat elevation system, which is awesome. We're expecting CMS to issue a proposal for coverage for standing systems in the coming months, and then we'll go through the process of CMS sends out its proposal, and then we go a couple months, and then submit our comments, and then they come back with their final proposed rule a few months after that. So again, exciting things happening in the world of access to devices. And both fortunately and unfortunately in the world of Medicaid, things have not been quiet. So as you may have noticed, as Congress was debating the debt ceiling a little while ago, there were some rumblings that work requirements might be included in the Medicaid program. We saw those work requirements in some form be included in SNAP and TANF programs, but we didn't see them included in Medicaid. That is in large part due to the effort of many patient communities, including ours. We partnered with a coalition that we work with very often, the Partnership to Protect Coverage, PPC for short, in order to create this grassroots movement, which many of you participated in, to inform Congress that under no circumstances would work requirements in Medicaid be accessible. I even went so far as to write an op-ed about it that I will put in the chat here in a second. And again, hugely successful was that program with PPC, but there's always going to be work to do. Congress has been signaling that it would sees Medicaid work requirements in Medicaid as palatable, and that they would be interested in looking into that as we come back around in future funding cycles. So we'll certainly let you know if we need more action on that. But did want to thank you for your efforts in helping educate Congress on why work requirements in Medicaid would be unacceptable, and flag that we're likely to see that issue come up again. In better news, however, there was recently published the Medicaid access rules. Those are actually 2 rules. And essentially what those rules are is the Biden administration attempting to communicate with state Medicaid agencies, as well as those that use those agencies, to basically ascertain what are the pain points in people accessing services in Medicaid. And we were able to submit comments on that in order to hopefully, again, ease those pain points and help people get better access to services under Medicaid. So the first thing that we did is we asked the administration to essentially create a better feedback loop between Medicaid recipients in various states, their state Medicaid agencies, and then between the state Medicaid agencies and the federal government. And in doing so, in creating that feedback loop, what they call the Advisory Committee and Beneficiary Access Group is the technical name for the program. Hopefully, this creates conversation between these 3 stakeholders, and we can ensure that people are receiving the services that they need and want from the Medicaid program. So we're excited to see that program essentially begin again. We are also talking spoke to the administration about home and community-based care services within the Medicaid program. Again, just trying to ensure that people have access to HCBS services, that they can submit requests for needed services and receive timely responses in looking for those services. We're hoping to get that resolution down from 90 days to 45 days, so a much faster timeline to get you answers on what you need and wait lists down with the HCBS program. And then finally, just looking at payment rates. So transparency in how much things cost the Medicaid program on the state level, as well as how much cost sharing is happening between patients and state levels. And looking at fee-for-service payment rates as well. So again, just trying to open up more lines of dialogue between state programs, beneficiaries, and the federal government. And then I would be remiss if I didn't finish talking about Medicaid, if I didn't talk about the unwinding process in the public health emergency. As you've likely seen in the news, the public health emergency officially ended a few months ago. And with the ending of that public health emergency, states were then allowed to begin redetermining people's status on the Medicaid program at that point. Various states will be doing that over the coming months. Many states have already started that process. You've heard from us talking about needing to update your address to make sure that your address is current, phone numbers as well, and making sure that you are tapping into the resources that you need to ensure that your redetermination process goes smoothly and that you don't get removed from Medicaid rolls unnecessarily or due to procedural issues. As we've seen so far, that unwinding process has gone quite poorly. We've seen upwards of 70% of people removed from Medicaid rolls due to procedural issues in the states that have begun that process and have begun reporting out data, which is obviously very grim. So we need to continue to ensure that people are getting their information to the state to make sure that they're, one, receiving their packets outright, and two, are receiving the help that they need to fill out those packets. But we're also not sitting idly by either. We've sent a letter up to the Centers for Medicaid and Medicare Services asking the Secretary to exercise their authority to pause redetermination processes when they have noticed that the redetermination process has unduly removed a large proportion of people from state Medicaid rolls. So essentially where it looks like there are a lot of procedural issues with redeterminations rather than issues, people being removed because they, for example, make too much money. So we're still fighting, still working to make sure that these determination processes are fair and equitable across every state. Mark, you can go to the next slide. And we're also continuing to work in the legislative space as well. As you heard during our last Advocacy Institute, or if you haven't, it's available on our YouTube channel. And as you honestly just heard, access to genetic medicine and precision medicine in general is on the rise. That's going to be hugely helpful to our community, where so many of the conditions that we cover and talk about are genetic in nature. And really the first step to getting appropriate treatment is, of course, being appropriately diagnosed, as was mentioned earlier. So we're happy to report that HR 3876, which was piloted by Adrian Smith with Reps Higgins, Balderson, and Sewell, among others, on the House side. And then on the Senate side, Senate Bill 2332 with Senator Barrasso and then Senators Tester and Blackburn co-sponsoring was introduced in the House and Senate recently. And hopefully what this is going to do, well, not hopefully, it will, if passed, increase access to genetic counselor services, which will in turn allow people to have themselves sequenced and hopefully get an accurate diagnosis so that they can then go receive that appropriate follow-on care. So we're very excited about this. And essentially what the bill is going to do, outside of the broad strokes of help people get in front of genetic counselors, is it incentivizes genetic medicine services by recognizing genetic counselors as treating physicians under Medicare. So that will allow them to build the Medicare system more efficiently and effectively, which will then incentivize hospitals to employ them because they can more effectively get paid, which is always helpful. And then it gives them a favorable reimbursement rate under Medicare Part B, which again will incentivize more genetic counselors to be hired in the first place, which is great. And then increases patient access by allowing coverage of these services both in person and in telehealth settings, which is great. As we know, getting access to a specialist can be incredibly difficult if you live in, say, Iowa and your closest specialist is in New York. Being able to access that specialist via telehealth is hugely helpful. Obviously, genetic counselors are not quite so far spread out, but again, being able to see them through both modalities is hugely helpful, and getting people in front of someone who can give them that appropriate diagnosis is awesome. So what can you do to be supportive? We've created an advocacy campaign on our website. There, you can input your address information and it'll pop out a message for you depending on whether or not the member of Congress has already co-sponsored the bill or whether they haven't yet, and it will either thank them for co-sponsoring or ask them to co-sponsor. And that's our big ask at this point, is asking those members that have not yet co-sponsored to co-sponsor the Access to Genetic Counselor Services Act, So please, if you have a moment, please take the time to go over to our website, access that campaign, and send a message to your member of Congress, because we're really excited about this particular bill as well as the others. All right, you can go to the next slide. So what else have we been up to? We've been doing a lot to ensure that insurance standards and medication affordability are continue to be front of mind for the administration. So going kind of in more recent order, one of the things that happened recently was the Biden administration put out a new rule on short-term limited duration plans, which maybe you may know better as junk plans. And the short-term limited duration plans were happened under the ACA marketplace. They were originally conceived of as these very short, like 2 to 3 month at most, stopgap plans for people that lose access to coverage one way or another. So let's say you were on Medicaid and then you start making too much money and then you get weaned off of Medicaid, but you haven't yet found, or you haven't gone through the process of getting a subsidy for continued coverage under the ACA marketplace, or you haven't found a job to get onto healthcare that way, or your job needs to take 2 or 3 months to get you onto their healthcare, something of that nature. These short-term limited duration plans were literally designed to just give you bare minimum healthcare during that short window. Unfortunately, the Trump administration, during its tenure, took various steps to widen the window of, one, what those plans could provide, and two, how those plans could be advertised, which caused a lot of people to end up getting stuck thinking that they were buying into a more robust health plan, but actually buying into one of these junk plans and then getting less adequate coverage than they thought they were going to be getting in the first place. Thankfully, the Biden administration has taken steps to essentially roll these plans back to their original construction of saying they can only go for 2 to 3 months at a time. They have to be advertised in specific ways so that people know what they're buying into as they're buying into them, so that hopefully people are better protected going forward. Similarly, as you've probably noticed with the recent approval of the therapy for Duchenne muscular dystrophy, which we're obviously very excited about, therapies for these conditions can be quite expensive. So again, we're monitoring how we can best be helpful to keep these costs for these medications down. As you may have seen, actually, to cut myself off, we spoke to the senators from Medicare and Medicaid services fairly recently. They have also taken note of the continued rise of precision medicine and genetic therapies, and they're very engaged in trying to make sure that they can pay for these therapies. So they're working with organizations like ours to brainstorm ways in which we can work together to ensure that these medications remain affordable and accessible for all patients. So we're really excited to see that out of the Biden administration. But then also, as you may have seen recently, Cigna had made an announcement that they were not going to be, Cigna among other insurers made an announcement that they were not going to be covering various therapies as they cost too much money, and various employer-sponsored plans had started making announcements that they were going to take deliberate steps to ensure that they didn't need to cover various therapies because they were expensive. And you will see if you go to MDA's website, we put out a statement essentially calling for insurers to appropriately cover all medications once they are appropriately approved by FDA. So we are monitoring both the public insurance space through Medicare and Medicaid, as well as the ACA, and private plans to ensure that they are covering these medications as fairly and cost effectively as possible. Or you can go to the next slide. And that brings us to the end of all of our content, to be honest. So I'm happy to open up the floor to questions if anybody has them. And actually, as I do that, I realize I've forgotten another step that we've taken is We've sent up a letter to the administration on what's called the Notice of Benefit and Payment Parameters. This happens once a year. And essentially what this program does, thanks, Mark. What this program does is it, similarly to the Essential Health Benefits Program, which basically says, under the ACA, this is what plans have to include. Notice of benefit and payment parameters is kind of the advertising end of that spectrum. And so what it does is it says, this is how you have to market plans to payers, similar to junk plans, to ensure that they know what they're buying into when they buy into these plans. So you can't call a gold plan and a silver plan the same thing if they don't offer the same benefit, because people are going to see, oh, gold means better than silver, so this obviously offers more coverage. It's things like that. So again, just trying to protect people and ensure that they're receiving the best care and insurance possible and know what they're buying into as they buy into things. So now that I've sufficiently skipped myself, happy to open things back up to questions.
And Joel, I think a few are coming in, but we had some that came in before that I think got a little buried in the chat box. When you were speaking about the seat elevation systems, was that Medicare or Medicaid? I know we put it in the Medicaid section, but it might be Medicare. I wonder if we could just clear that up real quick.
So it's actually both. CMS covers both. We just typically see it more in the Medicaid section. But yes, you should be able to access it through either program.
Great. Actually, we have quite a bit coming in here now. So Denise asks, I think Denise asked a great question. Does this mean that the insurance companies on the marketplace plans have to be clear about what they do and do not cover?
Yes, they do. So every year, both the Essential Health Benefits Program and the NBBP is the short version. CMS comes together and views both of those programs and attempts to make sure that people know what they're buying into. So yeah, that's essentially the purpose of those programs.
That's great, because it can be so confusing to know what the plan actually does and does not cover. Sumuka has a great question. I know, Joel, this is perfect. I know this is a little bit of a different webinar, but I know you can answer this. Is MD advocating for more funding for home and community-based services to address the nationwide shortage of support professionals?
We are.
Yep. Go ahead, talk about that, Joel.
Yeah. So we've been advocating for increased funding for HCBS for years now. We were very excited to see the Biden administration in their budget last year increased funding for what's called the Money Follows the Person program, which is essentially a pot of money that states can use to bolster their home and community-based care services for year over year. So we were excited to see that. But also, there are three bills working their way through Congress: the HCBS Access Act, the Home and Community-Based Care Workforce Act, and the I've forgotten the name of the third one, but there is a third one. And I can follow up with you about this, Samuka, if you'd like. But essentially, these three bills all also attempt to bolster HCBS programs by, one, ensuring that workers participating in these programs are paid better, trained better, and recruited better by their states, and then also are funded better in general via the programs. And then also, one of those bills seeks to make HCBS an entitlement, so removing the many people that are on these wait lists and just giving them services outright as an entitlement. We're probably still a little ways away from that one in particular, but we are continuing to work to make sure that HCBS, one, remains well funded, and two, that we're supporting the workforce as we continue attempting to make improvements to the program.
Right. And Sumuka has actually a part 2, which is about income limits and removing asset of income limits for people living with disabilities. That is another webinar in itself. We have another government relations director who works on that. It's more of our empowerment independence portfolio. So Sumuka, I'll connect you with Michael on our team who can talk about that. That'd be another person of our team that could probably speak more in depth about that.
And what I will say in terms of asset limits in HCBS is one of the provisions of these bills attempts to remove what's called the spousal impoverishment provision from the appropriations process and makes it permanent. So it is a thing right now because, again, the Biden administration fully funded these programs last year. But basically, what this program does is if you are married to someone and you do not yourself receive HCBS services, but your spouse does, what it does is it takes your income as the spouse and removes it from consideration so that hopefully it makes your spouse's ability to get these services um, easier for you and you're not punished just because you're married.
I feel like a lot of these questions are for Joel. So if you have any questions for Megan and Lindsay, please put them in as well. We'd love to have those questions for them. But another one for you, Joel, is about any headway we're making in advocating for affordable medication under Medicaid or in general. I know there's a few things we've been working on with either the Inflation Reduction Act or other stuff, but if you might want to take a stab at that.
Yeah. So unfortunately, there's not a ton that we can do in how private insurers cover their medications, but we were really excited last year to see the passage of the Inflation Reduction Act, which is going to do a lot for medication affordability under Medicaid Part D in the coming years. So in 2025, we're going to see an out-of-pocket maximum of $2,000 a year for medications, and then a smoothing mechanism for that program, which basically it allows you to pay. So you're capped at $2,000, but then also rather than having to pay that $2,000 at one time, that smoothing mechanism allows you to pay that $2,000 over the course of a year. So hopefully that medication doesn't hit you quite as hard all at once.
I think we have another one from Samuka again, which it says if we're working on any initiatives to increase the accessibility of healthcare facilities, not so much. I don't know about facilities, but Joel, weren't we working on something about like accessible equipment, such as exam tables, that sort of thing? I wonder if you expand about that.
Yeah. So last year, the U.S. Access Board put out a rule essentially asking manufacturers of diagnostic medical equipment what are the safest and most feasible heights for diagnostic equipment that you can create. And so we, among many others, weighed in basically saying, here's the minimum height that that is safe for patients to transfer out of. So we're talking about things like the height of an MRI bench, or if you have to transfer out of your wheelchair to get onto a chair for an X-ray or something of that nature. And so thankfully, a couple of months ago, the Access Board came out with a proposed final rule saying, okay, we've heard your feedback and we're going to lock in at this lowest possible height for this diagnostic medical equipment. They then asked for further feedback from these manufacturers, talking about a timeline. And so that will be wrapping up here shortly in a couple of months. And then once that wraps up and the Access Board takes that under consideration, that rule will become final, and then we'll go from there. But essentially, the short version is here in probably within the next year or so, we should see a minimum set standard for things like MRI benches, which will make it safer for you to transfer or simply get onto these diagnostic medical equipment, which will hopefully be safer for patients.
Great. And Denise has a good question. I think that Megan or Lindsay could answer is regarding the personalized medicine caucus. She has a two-part. I would ask our representatives of our state to join. And could you explain what the purpose of that caucus is and what we can do?
Yeah, I'd be happy to take that one. I just dropped a link in the chat to provide you some direct access to information about the caucus and to look at the list of the members in Congress who are already a part of the caucus. It's a fairly new caucus, but growing the caucus is an important area of focus for them. So yes, if you are in contact with your members in the U.S. House of Representatives or the Senate, we would love if you would ask them to join. And the purpose of the caucus is, I know we focused in on two particular issues, but their goal is to look at a wide range of policy issues and just promote general awareness of things that are happening in the field of personalized medicine. So they do everything from working on legislation, working on appropriations requests, working on report language, facilitating conversations by promoting education or by holding educational events. They are often going to stakeholder activities as well to share information and to hear feedback from stakeholders who on issues that are important for different subgroups within the personalized medicine community. So I hope that gives you a little bit more of an understanding of the types of things that they're doing. And certainly they are paying attention to issues that are relevant for genetic testing and beyond.
And Megan, just to follow up to that, a lot of times when folks always want to know is a caucus partisan? Is it bipartisan? May talk about, although I think you dropped a link, but it looks pretty bipartisan, right?
That is absolutely the goal, is to make sure it's bipartisan. And these issues, we don't believe they should be partisan issues. So we really would love, in particular, to see more Republicans on the caucus. I know it's a big goal because we deeply believe that these issues should be advanced by both parties.
Joel, I think you're on mute. Looks like we've got one more follow-up from Samuka, which is there any mandate about Hoyer lifts or ceiling lifts or accessible examination tables or more training? I think he just wants some more information about more accessibility in a doctor's office or healthcare offices.
Yeah, so unfortunately, the Access Board's ruling only applies to diagnostic medical equipment. It doesn't extend to what those offices have to provide. But honestly, I think that might be more of a Michael question, Rick.
Yeah, that might be a great question for our other government relations director, Samuka, about that. And see so we'll take that question back to him and see if there's something he's working on. And we appreciate you reaching out, because sometimes it could be that we take these questions and realize that we need to work on something. So this is good feedback from you, and we'll talk to our other a lobbyist and see maybe he's working on something as well. But thank you for the question. We appreciate that. Joel.
Yeah, so I was just going to put out one last call for questions if you have anything for any of us. And if not, we'll wrap up a little early. Okay, well, seeing none, I'd like to take a second to thank both of our guests. You guys were awesome. Thank you so much for that great information. And thank you all for attending and asking such great questions. And we hope you all have a great night.